No.
All right. Hello and welcome again to another Down Fracture podcast, a podcast for talking jaws. Down Fracture Podcast at gmail.com. We have YouTube, we have Spotify, we have Apple Podcasts, all these wonderful things. We did get some feedback this week, which we appreciated, some nice, kind words from listeners. Sam, how are you holding up with your Mariners
Oh man,
stress and
it's lovely.
excitability?
Oh, I mean, it's wonderful. I went to game 5 last week and it was the best baseball game ever. It was the best.
Did you stay all 15?
Oh yeah. Yeah, I mean, it was outstanding. Afterwards, I mean, the salmon race really pushed us over the edge, and Humpy was quite the celebrity following the game. You know about the salmon race, right?
I feel like I don't now, and your
I
reference of
can't.
Humpy is disturbing.
And so you consider yourself a Mariner fan, right?
Kind of.
Okay.
I'm not a
I think
big
that makes
baseball fan, but I follow it and I follow it enough to know what's going on when the postseason arrives, relatively. And then I generally will watch the postseason if I feel like there's either a team I'm invested in, such as the Mariners or the Cubs, or there's like a good storyline. Red Sox, Cubs,
yeah.
Indians
Playoff baseball is the
winning their
best.
first, World Series or stuff like that. So I would say yes, as far as my baseball fandom goes, it's kind of Cubs and Mariners.
Nice. Yeah. So they have a salmon race started a few years ago, 2, 3 years ago. It's kind of like the is it a pierogi race? What do they do in Pittsburgh? Hot dog race, whatever, the sausages.
Oh, you're talking about Milwaukee? Is it Milwaukee that does that?
Milwaukee does the sausages, Pittsburgh does the pierogies, something like that.
Mm.
Anyways, Mariners do salmon racing, and they do different types of salmon. It's king, silver, coho, and humpy. Humpy is the type of salmon. Um, and Humpy had a complete losing streak. He had never won. I've taken my kids to many games, and they always try to cheer Humpy on, and he always gets demolished. Anyway, in extra innings, we were on our second salmon run because the game was going so late in the middle of the 15th inning. And Humpy summoned all of his strength and won the salmon race, and it cheered everybody up. Mariners started hitting, we won the game, and everyone. I mean, I was convinced it was because of Humpy, so it's lovely. I can't believe you don't know this, so I'm glad I was
I
able
did not.
to catch you up on that because they're back at home today, so we got to finish up today so we can watch.
Right. Yep. Yeah. I mean, we generally, because we're not the biggest baseball fans, we try to go to like one game a year. When we were in Seattle, we would take them to like a Mariners game every year, just like we kind of take them to a Diamondbacks game every year here. But I don't remember salmon races. It could have been happening and I was just unaware.
Yeah, it's kind of a
But
newer thing. Yeah, it's fun though. So
cool.
let's see, what are
Yeah.
we talking about today?
Oh, I think we just decide on troubleshooting custom TMJ replacement.
Yeah, I think troubleshooting the fit of controller devices and BOSA devices. I think this is a true one. So, placing TMJ replacement devices, the Striker TMJ concepts. I think when you're initially learning, you think everything's going to fit perfect and it's going to be totally straightforward. And the easy part is putting the devices in. Is that what you thought when you were training?
A little bit. Yeah, I mean, I'd
Hmm.
experienced not a lot, but enough to know that that wasn't always the case. And I kind of always viewed it as like like a way of like knowing if I had done adequate surgery. Have I got enough soft tissue out of the way? Have I reduced enough condyle? If things don't fit, then I must not have. But that's not always the case, which is what I guess you're getting at a little bit here, right?
Yeah, I mean, um, knowing that they're not getting seated incorrectly, I guess knowing that they can be seated incorrectly is the first step. And then recognizing what's going on while surgery is going on is tricky because you can get CTs after the fact and say, oh, look, the fossa is not seated completely, or the condylar component didn't resect enough. And so the condylar head's lateral or something like that. And, being able to kind of develop the kind of ability to figure that out as best you can during surgery.
Excuse
Because all of your devices fit perfectly, yeah.
I wish. No,
Um,
not always. I mean, I think that's like one of the difficulties is defining what is good fit which is what I think you were kind of hinting at there is
yeah,
like they don't all on CT after the fact completely hug the bone 100% of the time. And what is the level of acceptability? I think sometimes it's tough to figure out because I've definitely been in cases where I'm trying to seat something and I feel like I've made it worse, especially like a faucet component. Like if I feel like I need to reduce a little bone or smooth something, and then I do that, and I'm like, well, I think I either that wasn't the right thing to do exactly, or I removed too much. And now instead of being a little bit bulky in the area, it doesn't seat in one area. And, did I make it better? Did I make it worse? And I think in real time, that's sometimes difficult to determine.
yeah. Here, let me share. I got a picture of a joint replacement device, just a generic one. I guess it's not generic, but when you're doing surgery from a preauricular and a retromandibular approach, or um, whatever your approach is on the neck, um, you can visualize the fossa and the condylar head, like where it's seated, and then you can visualize the angle and then looking up to where the condyle is, right? And it's
Mhm.
hard to visualize both of those at the same time. And you can
Mhm.
have your lateral view look great. Like you can put the device in, the fossa looks good, the condyle looks good, and then you get an x-ray and it doesn't look so good, right?
Mhm.
So um these are, I think, the things to kind of improve upon, and I feel like are good tricks to kind of like talk about in terms of how that happens, because you know the the condyle doesn't have just one spot, right? Like it's a flat fossa, and they typically design it to where it sits roughly in the middle of the fossa. But and then trying to recreate that position, I think, is important, right? So getting the condylar head or the prosthetic condylar head and the posterior aspect so it's up against the lip, but is ideally in
Mhm.
the middle as possible, because there's kind of a bunch of things that cause
You
these
mean,
things be misfit.
so hold on, let me just make sure because I think I know what you mean, but I'm not sure listeners would. So you're saying from a positioning standpoint, generally you want it to be kind of in the AP dimension pushed towards the posterior lip because there is a posterior stop in the custom device faucet components. But from a medial lateral standpoint, you're saying when you say middle, you mean from a medial lateral orientation?
Yeah.
Yeah.
Yeah, I
Okay.
mean, like looking from below, this is always a weird view. I don't know why they have this
I know.
upside down,
They
but
always put that in there.
like, come on, just flip it around. But I think they design it typically to where it sits roughly in the middle, right? So the
Mhm.
condylar head seating medially or seating laterally, particularly if it's partially off of the fossa, medial or lateral, is a good tip that something is awry.
Mhm. Definitely, because I will say I've encountered that sometimes you don't know the faucet component is off as you're kind of hinting at here until you try to put in the Ramus component,
Yeah. Oh, yeah.
because
Because it could be
it can
either one,
see.
actually.
Yeah, and it can see like you're looking at the metallic portion on the lateral aspect of the fossa, and it looks like it's fairly flush with the bone. You put the drill on it, and the bone's right there. You even put screws in, and it's right there. But it's actually ramped up and kicked out where it's angled laterally, and then you go try to put the ramus component in, and then and only then do you kind of realize it. That's definitely, especially when there's heterotopic bone ankylosis, those things that happens,
Yeah.
and it can be
I
tough to
mean,
figure out.
in the absence of ankylosis, the fossa kind of tipping down medially is generally the dissection plane, right? Like it's just generally soft tissue, doesn't have enough room for the entirety of the fossa.
Mhm.
And I like to use digital exam to ballpark that there's enough room there. Because placing the fossa, it's very easy to put the screws in, but then have it tipped out because you can't seat it far enough medially. And so,
Mhm.
because it's reasonable, it's I think a lot of people, it's reasonable to be cautious on the medial dissection.
Mhm.
But at the same time, you do need to seat the device. And so I found like revision cases, people had a bunch of surgeries in the past. They have soft tissue that's really fighting you with scar. It can be hard to kind of do that and feel comfortable like cutting through scar to create enough pocket to seat the fossa. Like you were saying, heterotopic bone is a common one where they come a different reason, but that does the same thing, which is the medial part of the fossa kicks down. And
Mhm.
so generally the condyle looks like it's medial, right? Like it's dislocated medially.
Yep.
You know, I don't know, at least when I learned about dislocation, it was always like anterior to the fossa, but you can dislocate anyway. Especially in terms of getting the devices, if the devices aren't quite seated in the best way.
Yeah, I'm a big proponent, even as I've gained more experience doing these. I still get FOSSA fit check guides, pretty much every case.
Man, I had one
I
of those
do
today.
that.
I didn't even understand what they wanted me to do with it. It had a hole where the fossa was. It was like it sat just in the same area laterally where you would put the screws, like predictive hole type thing. And
Mhm.
then it was to seat in the fossa, but it was open like a toilet seat. And I'm like, is
Hmm.
that how they're supposed to be?
That's not how I think I know what you're talking about. That's not how I get them. Mine is like usually it's the cheaper version because you can get like titanium or you can get metallic, like more rigid guides that are more durable, but I don't think you need that. But mine, I mean, my understanding of the ones that I typically get are they're basically mimicking the metallic framework,
Yeah,
right?
exactly.
Like it just doesn't have the high molecular weight polyethylene or whatever on there. And so like if you could fit that in there and it doesn't rock, I usually don't drill the holes. I
Yeah,
usually don't
sure.
do that. I put it in there to make sure, like you're saying, have I scraped all the soft tissue off to where this is going to fit solid? Do I have a big enough pocket to where the medial aspect of the framework would be able to get in with relative ease? I think the other ones, anterior and posterior is not always a given either, because
It
sometimes they
isn't.
have to design those components to extend further AP wise, because sometimes you don't have good bone along the lateral aspect of the fossa or the arch,
You know,
and they have to extend them. And so sometimes you have to go back and remove more tissue posteriorly or dissect more posteriorly or anteriorly. So I really like just putting those in because I'm a big advocate for not taking your actual components in and out. Like I think that's just problematic for scraping things, scuffing things up, make sure PGI, your prosthetic joint infection risk go up. I try to do everything I can to avoid that. And I found that those fit guides help quite a bit.
yeah, sure. I mean, using a seating guide, you still run into the pocket problem, but definitely for reduction
Mhm.
and seating of the fossa. Yeah, AP is a good point because masseter attachments kind of get in the way of seating anteriorly. So if you don't get up there and release those, what do you use the seating guide for a joint replacement? You did the formal course, didn't you? Does that
I mean, I
tell you
did
to
the
do that?
TMJ mini residency. When you say the seating guide, what do you
Or the
mean? Like that?
seating tool that comes in the
Yeah,
kit?
the one that has the smooth rounded ends that almost look like chromium, cobalt, molybdenum, like the components,
Yeah.
but it's like a 45-degree angle or something on it. Yeah, I use that. I mean, I use my fingers sometimes too. I've used the
Yeah.
Selden.
See, I'm big on fingers just
Yeah.
because I can feel it, right? Like I can rock it, I can push it
Mhm,
back, like um, because you're coming from below, right? And then you're seating the
mhm.
fauces with your thumb or your index finger, and you can push it on the eminence, right? So you can seat it on the eminence, and you can push it, and then you can kind of rock back and forth, and then medial side to side. And it's still hard though. Medially it can kick down, and so that's
You
still
can easily get soft tissue trapped under there and have no clue.
yeah.
Like you really can't. I mean, I think that's sometimes. I think that probably happens. When you get some post-op CT, it's kind of like that image you showed. Like it's not always to that magnitude, but like you could see, like looks like there's a little something under there. But I think you could do that with the seating tool too. Like I just do the
Yeah,
same thing you're
totally.
describing with the seating tool, and I put my thumb on the lateral metallic aspect of the faucet component, and then I do what you say. Like I kind of move it like the prosthetic would. I move it AP, and then I try to rock it medial lateral. And as long as it's not feeling like I don't feel movement at my thumb where I'm holding it laterally against the lateral fossa and arch, then I feel like I've got it in the right place. And I do that with the fossa, like the seating guide too, the fit guide, and then I do it with the actual component. I feel like that's reasonable. Sometimes it's hard to get your finger all the way up there.
Yeah, you use dilators. Am I the only one that dilates? I think I'm the only one.
I think you are. What do you use those? Like, what are you
The
using? Like,
Hagars, yeah,
yeah,
just to
I think that's
dilate the path
reasonable.
and dilate the entry of the
I
faucet.
just take a Selden usually and like put it up there and pull, like kind of stir it around a little bit, and then make sure I can get a middle finger through it pretty easily.
Yeah, I mean, I think it's you can only reposition faucets so many times. I think your point about kind of minimizing in and out is a good idea. Because if you put it in and you're looking at it and it looks wrong, it's got to look pretty wrong for you to want to take it out because um you got to drill new holes, right? And it's pretty easy for those holes to turn into one big hole, especially if it's just a little bit off. With tipping, that's a problem, right?
Mhm.
Because the new holes tend to move down a little bit. Um, so it doesn't allow you to like drill the holes, put screws in, take them out, take the device out,
Yeah, do you?
put everything back in, re-drill, new screws,
Yeah, one of
recheck, take
the
it out.
one of the things for less experienced listeners may be, and I think most of us who were trained in these things or taking courses, like one of the things that a lot of people advocate for is not using all your screw holes. Like just put two screws in, and even put in just a few screws on the ramus, do that on both sides, check your occlusion, make sure it looks good. If it looks good, then go back and finish your holes.
Hmm,
Do
you
you do
could do.
that or did you ever? Yeah, I mean, I don't really do that either. Um,
It's just, I
but
mean,
it
yeah,
makes some sense. If I was unsure, like if
yeah,
things were
for sure.
not looking good, I would give that strong consideration, especially in the fossa. Um, but I think maybe my first few cases, I think I put in most of the screws and then like went back into the mouth, like out of paranoia to like check and make sure I was still in the splint. And then I went back and finished, but I haven't done that in a long time.
Sure. Yeah, I mean, I typically just see the devices close, seat left close, seat right close, check the bite. But yeah, so fossa, soft tissue, and then bone removal, ankylosis cases, because you're coming at it in a direction, you're worried about getting in the brain, that you tend to shy inferiorly. And so those are really good cases to have a fossa seating tool of some kind. Um, and then the condyle is not removing enough bone generally, right? So on the Ramus, um, you know, they make those devices with a little bit of a lip to them, and that lip can catch bone if it isn't reduced enough. And so I don't know, I think I probably use my fingers more than I should on TMJ replacement, but I had learned at least that you need a finger width from the resected ramus to the lip of the fossa. Like you got to put your finger in there and feel like there's enough room. I'm not sure why that was. I think Spag told me that. But I think it's a general rule of thumb. I don't think it's bad. So it's something that I check to make sure I'm not pinching soft tissue. And sometimes you're a lot closer there than you think, especially if you keep the cornoid process, you know.
Yep,
So
for sure.
giving yourself a little room there, I think is good. But you know, it's hard to see that you have under resected the ramus until you see that the condyle is lateral.
Mhm. Or you just, I mean, sometimes you don't even see that it's lateral in my experience. Like there's just been times where I've tried to seat it and it's like rocking or it's not seating flush.
That's
And
why
you
I like
think
it.
what's that?
Yeah, no, that I agree with what
Yeah,
you're saying. I
like
like this
100%.
picture for that reason because it's
Hmm.
like the fossa is tipped down, so the condyle would be medialized, and so then the condyle is tipped out, so it should be lateralized, and those two like cancel each other out to look good. You know what I mean?
Yeah, I know exactly what you mean.
Yeah. So like anyway, so the resected bony part allows that to go, and then also seating in the right space side to side, right? I mean the side to side. See if I can get a picture of a joint replacement device. Um, I can't really find one. Um, the devices, you know, if you have masseter, a little bit of masseter still hanging out there, a little piece of bone, or um, the devices fit well, but they don't fit perfect. And so if they're rotated forward or rotated back, they can wiggle a little bit, like you're saying. And if you put a screw in and it's wiggling and you like push it down, it can tip the condyle medially or laterally.
Mhm.
So
Mhm.
I don't know. I think being on the lookout for those things. I guess now that I've done a fair bit of these, I appreciate all this a lot more than I did when I started. Like after fellowship, I get into work and life. I thought I already knew all this stuff, but there's really little things that are pretty good to be on the lookout for.
Yeah, I know you're a fan of what I'm going to say because you said it to me before, like when I'll show you post-op x-rays and stuff. And it's what I kind of tell the residents is, a lot of that ramus you don't need.
Oh
Like
no.
you do need to be aware of where the lingula is. You need to be aware of some anatomy there. You don't want to just get careless in how you're going, deep medial to the ramus there. But like with a Kerrison or a Rongier, which I know again you're a fan of the Kerrison there, you can remove some bone and you don't need it. So like remove more than you think you need. Like so, make your initial cut where you think you need it to be, and then either remove some more or kind of take that initial cut and make it lower. Where if you're making the cut where you think it is, make it a little bit lower or make it and then just without even like make it part of your process. I'm going to take what I just removed and then I'm going to remove more with a Kerrison or a Rangier or whatever, just like as a part of your normal process. Because you don't need it. Again, as long as you're not getting in the lingula, you're not going crazy on the medial ramus. Like you don't need that bone. And even the misconception, because I think it's a common board question or one of those kind of on-site questions is always like, which screw takes on the most force? And it's the most superior screw. And I think that's sometimes misunderstood. And I think people believe that that screw is somehow like the screw like on the device. Like I have to put a screw in the most superior planned screw. I
Yeah.
think that's how a lot of people interpret that
Yeah.
instead of just from a physics standpoint, whichever screw ends up being the most superior, that one takes on the most force. And so I think they misinterpret the importance of having all that most superior screw. And I would almost say, and I know again you're kind of a fan on this, I would err on the side of like, who cares if you don't fill that screw hole? And I frequently don't. Like, I mean, I frequently remove to where it doesn't, or what there's not enough bone to really support a good solid screw, and so I take it out. And I think that just speeds things up
Yeah.
and prevents you from having the problem you're describing and showing on that image.
Yeah.
Because it's easy to make that mistake. And I've had some where I'm like, oh, I removed a ton of ramus bone, bone from the lateral ramus, and I'm like, then I get my post-op CT, and I'm like, man, that actually was still kind of hugging the ramus component, and I actually probably should have removed another few millimeters. So I think that's another little tidbit is like, don't get caught up on you got to make all those screw holes fit, or you got to use that most superior screw. Just you don't need that bone. Save yourself some time and headache, and just remove it.
Yeah, I agree. I think I heard a Rongier in there. Is that what I heard? I think you had Rongier. Is Rongier an alternative pronunciation for Rongier?
I think
I got
you
off
can.
on a whole different tangent in my mind about Rongier.
How do
Kind of
you
like that.
pronounce it?
I think it's Rongier. Is that
Ronger? I think
Rongier?
I say Rongier.
Huh. Well, there you
I
go.
guess yours
This
probably
must be
sounds
like a
better.
Midwest thing, like a
I think it's a Southern thing. I
tomato
think, I
tomato.
learned it when I was in Texas.
What's
Um,
Midwest? Bag, big
Vague.
versus
Oh,
bag.
that just doesn't make it. Packet. Like you
Uh,
can't tell if they're saying packet or pocket.
yeah, there's a lot of
Uh,
them. Yeah, but I mean, I agree. I think that top hole. I mean, I frequently have those open, and I have no problem with leaving that empty.
right.
So yeah, so that's no problem.
Well,
Um,
what is well, do you have anything else you're going to add to this whole
well,
portion
yeah,
of
I was gonna.
things?
I'll put the bug in there because I do meet people who don't practice in this way. I'm a fan of splints always for TJR,
Hmm.
like always. And the reason for that is the other reason why devices don't fit is because your mandible's in the wrong position, right?
Hmm.
Because the mandible's got a little yaw to it. That's a little bit hard to see inside the mouth. If you're doing a big advancement case with counterclockwise rotation and you haven't seated them completely, like flat occlusion or because they really slip around if you're just wiring their teeth together. Or if they're like, partially edentulous, that sort of thing, the jaw
Yep.
can shift. And so, you're pushing on it, but to drill, retract, the head's turned. So there's some pressure on the lower jaw and that thing can move. So try to make sure that thing's in as stable, IMF as possible. And, I was the time, I think Andrew has told me this. Um, I had a case where it was the occlusion was really flat and it was really just sloppy occlusion, hard to make the teeth together. And she just asked why I don't always have a splint, and I didn't have a good answer for that. I use splints when I change their occlusion or when I had an intermediate position. I didn't have one just for run of the mill TJR, but now I do because it is nice to hold the mandible in a spot because again. Everything can be perfect about resection, dissection, all that sort of thing, and then the mandible itself's in the wrong position. So
100%. I use it or I have one every time. I will throw out there that sometimes, especially when you have these patients with severe limited mouth opening, that your optical scan or your impressions or whatever you're using isn't completely accurate. And so I've had splints where they don't really fit well for that reason, because you can't really get the occlusal surface. They're sometimes fabricating them off the CT scan.
yeah, but I mean, they
Uh,
keep them from wiggling around, though. It's like
oh yeah,
I mean, yeah, it's not like a perfectly fit split, but it definitely stabilizes it, which is nice.
no, yeah, I get it. I get it on every case, but I've had a couple where it's like, all right, this just doesn't even really fit the teeth. Like we weren't doing an amyloplasty or whatever. And these were people who couldn't open at like 5, 6, 7 millimeters. You haven't run into that?
No, no, I hear you. It's definitely a problem. I mean, making splits from just CT data, it's not the best. But I mean, what else are you gonna do? You got to use something. I mean, intra-op I've used things to kind of stabilize it, but I've never really liked it. So, um, anyway,
So let's take this, unless you got something else. I was gonna say, well, what do you do in the instance that you don't feel like your components are fitting? So let's say you get in there and your components aren't fitting. Are you
yeah, that's
then
tough.
trying to make them fit as a first line step? Like I'm removing bone, or I'm trying to figure out why they're not fitting and adjust things. Do you accept a certain level of
Well, because
ideal fit?
fundamentally, I think it's good to be trained in both systems. In America, the Biomet device, because the stock device, how you make that device fit is how you troubleshoot custom devices that aren't really seating as well as you like. And
Right.
so, I'm a big fan of custom devices, but there are times where stock works great, and I think it's good to learn both of those because they have overlap. And I think I am partial strongly to making the devices fit. So figuring out what's going on, and not giving up on the devices rather than just kind of setting them aside, putting in spacers, and then ordering new devices. It's just such a delay and such a big deal to go to the OR, and patients are having a hard time, so it's nice to get them healing rather than waiting on healing. So I think it's just be patient and kind of work on it. That's probably my advice with that. I mean, how do you approach it?
The exact same way, but I have had, again, ankylosing heterotopic bone cases where I couldn't get them to fit, and we had a big meeting, or not like a big meeting, but a meeting with the planning people about why that occurred, and there's various reasons why that occurred that I don't know that it's appropriate to go into, but I generally agree. And I think there's a couple questions in there of like, well, what do you do to try to get them to fit? And I think that for the most part is self-explanatory. You got to either remove bone
Yeah, I mean,
or
ankylosing cases, that's why people two-stage it. It is
yeah.
tricky seating the devices. And so it isn't the removal of the ankylosis. I thought it was just because the removal was a big enough operation that you didn't also want to put devices in there. It's largely because of what we're talking about. The fossa
Mhm.
cut is tipped down. Maybe it's vertically in the wrong position. Vertically is not the end of the world, by the way, but as long as you understand how that affects the condylar component. But those sort of things, um, are the argument for why you two stage, but I like one
Well,
stage.
I learned through some hard ways that you really, when you're doing your planning meetings, you have to be really careful of looking at the bone, because sometimes the planners, the engineers, they look at bone that they see as almost like floating, like, hey, I've got some heterotopic bone, not true ankylosis, like it's not fused. And they will look at that and just think, hey, that's just going to come out. Like, and then you get in there, and the reality is, the radiographs are lagging a little bit behind what's going on clinically, and that's a part of a fused bone.
Yeah. You're almost better off
Uh,
just designing it to a flat condylar
yeah,
head resection, right? Like just cutting
yep,
right in the middle of the condo and then
yep.
just putting the foss on it.
And so I think that's a lesson that I've learned along the way of like sometimes when you've got this heterotopic bone, it may look like it's floating in their minds as non-clinicians. They're seeing that as like, okay, when they go in there, that's just going to come out. Like it's just loose heterotopic bone pieces. And the reality is it's fused. It just doesn't appear that way on CT yet. And so you're trying to like troubleshoot that in real time. And you're like, well, we didn't plan on, having to cut across here or whatnot. And that could be tricky. Learned that one the hard way. And then, yeah, I think if you run into it and you can't get it to fit, um, I think you are having to wire, you put in a cement spacer
Yeah.
and potentially wire them shut.
Yeah. I mean, big delay is probably the problem with that. But I mean, you got to do the right thing, right? I mean, having devices
Yeah.
that don't fit and they're not going to last is not a good game plan. So, doing the right thing can be hard. But
Well, I mean, that's the troubleshooting part of it is I mean, you're trying to, in the middle of that, figure out, well, do I just put these things in and have some kind of functional device and then rescan? But then you make the case of, well, now my next scan is going to be inaccurate, or do you put in a cement spacer and think that your follow-up CT scan for a new device is going to be more accurate? Because I've kind of had that dilemma, like, do I just put in devices that don't fit perfectly? Because then at least I'm not having to like wire the patient shut and make them miserable. But I don't know that that's the right thing to do. I think
yeah,
the
I mean,
spacer is the way to
um,
go.
I don't know. I think this would be a good one to talk about with more seasoned people. I mean, I don't have a ton of experience with this. Um, I think generally I can get devices to fit, but I'm sure there'll be a situation where it doesn't. And putting spacers in, I feel like is prudent. It is, right? So I think I like that better than devices that you feel bad about. I mean, there are times that I've grafted and I mean it was solid, but not like as solid as ideal. But that's very much like a judgment call, like any in surgery, right? Like,
Yeah.
so always tough, but hopefully there's a tip or two that listeners or residents had heard today about when they're doing their next TJR. Um,
Well, let me. I guess we're going to wrap this up. Let me ask you one more question. So you do get your post-op imaging, your CT scan. I assume you're not getting that in the hospital. You're getting that back in your office, a week
yep.
later, whenever you see them. What is that? I mean, are there certain thresholds? You showed that image up there earlier, which I think is a great image, but are there certain thresholds where you're like, I've got to go back in? Or even if it hasn't happened to you, like, do you have some criteria in your mind? Because I've had some where I'm like, that's not fitting perfectly, but the patient seems to be doing okay. Like, do you have a threshold where you would just say, I immediately got to go back in, or would you kind of wait and see how the patient responds and only go intervene if you felt like there were symptoms going along with?
Yeah, I mean, because it go back and forth on that one. I think if they were doing well and they weren't dislocating and their jaw wasn't unstable, and the X-ray was kind of like it looks otherwise good, but maybe the lip of the fossa is there's a millimeter gap or something like that. I'd be partial to just leaving it. Um, I think that the enemy of good is better, right? So it's got to look pretty bad for you want to kind of like intervene. It serves as a good baseline. You can learn from post-op CTs and kind of like, you know, improve upon in the future. Um, I think that image, I'd be a little partial to maybe taking that one back, but that's
Why?
somewhere else. But I think the
Why? Why would you be partial to taking that one back?
uh
Like, I mean, I agree. It's a good amount off.
well, it's just more just like um there's a couple of troubles that can come up. And opening and taking the devices out does put them at opening a second opening, right? So infection rate would in theory go up. Um obviously you want to go after something you can improve upon, and I think that's one that you can improve upon. I've only had a handful gone back, and it's generally in dislocation cases, by the way. So I think
Mhm.
a condyle dislocating posterior or medial or something like that. So
I think that's a tough dilemma, right? I mean, the dislocation to me, I think is pretty easy. Like that decision-making process is like straightforward. You can't leave them
but
dislocated or prone to repeat dislocations.
I mean, I think that I mean this isn't entirely true, but a lot of times persistent dislocation, the devices need to be seated a little differently, you know? I mean,
Yeah,
it's
that's
obviously
what I
not
mean.
always the case, but
That's what I mean. I think that decision making is easy. I think where it's hard is like even that image you showed where I would agree that's pretty substantially off, but like it's not a guarantee that there's going to be problems
yeah, sure.
or what if they're 15 years down the road? Like I mean, I think things like that make it tough because just because it looks bad doesn't mean it will have a problem, and some of the ones that look great do. Um, so I
Yeah.
think that's always been my conundrum of like I see some and they're a little bit off, and it's like, well, what's the threshold for going back in there?
Yeah, I mean,
Um,
I I think in that situation, like that picture that I showed, I think talking about it with the patient, feeling them out, what they think about it. Like, hey, I think I can get this a little better, but I got to take you back to surgery, and patient will lead you the right direction. So I think it's a judgment call.
okay, well, what would Andrea or Wanda do?
Wanda's not here. Andrea, what would you do in that situation?
Oh, sorry, I wasn't fully paged.
Are you
If
taking
the
that back? Post-op X-ray doesn't look good. Patient looks good.
patient's otherwise fine. That's
She's
symptoms.
I mean,
she's
because
one of those
at 1 week, that's tough, right? Like
Yeah,
you
yeah.
don't know how you don't really know how the patient's doing in 1 week. Like you really don't. Like maybe, I
I
mean,
mean,
you may have to make that call later.
yeah, I think um I still stand by if it's really seems wrong, then taking back's the right thing to do. If it's just kind of like it's a B plus or an A minus or something like that, probably continue on with it. So, but talk to the patient, kind of feel them out.
All right.
So
And what's the concern about that Ramus component not seating well? Like, what are you worried about?
the ramus component not seating.
Yeah, like how you were
Well,
showing
my
in that
understanding of
image.
the biomechanics of the device is the weak point is the screws.
Yeah.
It's the screw interface, and so it's like there's that roughened titanium, and I used to think it gets integrated, but I don't know about that. It seems like the screws are holding that thing in there, and so the it was a weaker device, and so device longevity is my concern. So
Yeah, I think the board answer for
did I fail?
pre-board people. Yeah, I mean, you got the right concept, but I mean, and I'm not saying I'm right, but my
I don't
understanding
know. It's been a
is,
little while since I went to the board.
I
Uh,
think I mean, it's all what. So you worry about osteolysis around the screws, and then you get micromotion, and then the whole thing fails. Is kind of I think the phenomenon of like you're saying, it's not as sturdy and stable, and when you've got space between the prosthetic and screws, there's risk of those screws getting some osteolysis and then more mobility, micromotion, prosthetic infection, or mobility. And yeah, I think that's the board answer
you doing
is
board review? You getting on the board?
no, I'm just smart.
Man, I'm glad. You're just like
I think our listeners
spare
would
time.
beg to differ.
Well, yeah, well, sweet. Yeah, no, I think that's good. I think troubleshooting devices, I think I always like to think of those things as fitting perfect, and there's only one spot to put it, but it's just not true. So
Yeah, for sure. All right, cool. Well, that was another Down Fracture podcast, a podcast for talking jaws, downfracturepodcast at gmail.com. All right. Thanks, Sam.
thanks a
See you
lot,
next
man.
time.
Catch you later. Go Mariners.
That's right.